Welcome to Johns Hopkins. I'm among the faculty that are here as your host, and I'd like to thank you. I've never been allowed in this room before, so. So you heard only the deans are allowed, and I do recognize that man over there is Mayor Bloomberg, so we are grateful. He apparently, so that means this room are all of the former chairman of the board of Johns Hopkins. So, but I am really pleased not just to be in this room, but also to participate in what is really hugely important. As a professor of public health, we get it in terms of what really matters. It's all the stuff that you do, even more so than my colleagues who I'm grateful for across the street at Johns Hopkins, the #1 hospital in the world. It's actually now #2 because all the Harvard hospitals got together and stopped voting for each one and put all their votes behind Mass General. And that's a U.S. News and World Report, which I don't think they exist anymore, but they still get the rating out. But seriously, it's a great hospital. It's a great tertiary care facility. And God forbid you need them, they're among the best in the world. But all you have to do is walk 10 yards in either direction of the hospital. And if any of you ever watched The Wire, that is the real Baltimore, and it's not the real Baltimore. This is the real Baltimore. Baltimore's a great place, but as all of you know, you have wire communities in most of your locations, and we certainly do too. And is it the tertiary medical care that's going to solve the problems of those kind of communities? Absolutely not. It's the stuff that you do. So I'm very pleased that we are at an era, healthcare, medical care. I know I'm a professor of public health, healthcare, health policy. I know a lot about that, but public health is my thing, and now lately data and informatics and using freeing the data, as Todd Park and now Brian Sivak says. But the resources are obviously in the tertiary care facilities of America. That is the single most expensive hospital in America, is the one that I go to for lunch every day. $1.2 billion for just 2 buildings. But now that through medical care, through public health, through the understanding of the ACA, I think we do have an opening. Several people have mentioned that. Now, of course, this conference isn't about medical care. It's about well-being of communities. So I'm very pleased to participate in this expansion of the service continuum to really think about holistic. And we have a great session. And I absolutely promise you, both because of the time of day and because there's a lot of firepower up here, but there's even more there, that we will leave the last half an hour. And I've been assured that we won't be penalized the 5 minutes. So we're going to move very rapidly. I'm going to be the moderator. We have 3 fantastic members of the group. They're up here that are real participants. We have Blair, who is from the Office of the National Coordinator, ONC, which is a unit, Office of the National Coordinator, didn't finish it, for health IT. They're the ones, I as a so-called health policy expert would have never guessed that we would have had health reform. Some of you may not know that as part of the stimulus package, not part of the health reform package, the Office of the National Coordinator, a little sleepy office, gave out how many tens of billions of dollars? Actually, it wasn't your money, it was CMS's money, but still has had a profound impact on the availability of information, medical information, but many people, including Hunt, including many of his colleagues, get it. It's not just about the medical care, it's about the entire. So we're glad to have him as a member of the panel. Mimi Toomey, also a Fed from DHHS, is another innovative unit. She's in the Center for Disability and Aging Policy of the Administration for Community Living, ACL, which is another innovation of HHS to the best of my knowledge. We'll hear a little bit more about that. And then Linda Gibbs, who is comfortable looking at the picture of His Honor up there because she's the deputy mayor of...
More uncomfortable.
Or uncomfortable.
I got away.
You thought you got away, but I noticed you had your back to him, which you can't you can't do in his boardroom, perhaps. But we are really grateful to Linda and to His Honor, who gets public health, and she's the, to the best of my knowledge, the deputy mayor responsible for health and human services. And New York has done a phenomenal job, and they have some challenges, as we do here in Baltimore. So each will have 15 minutes. I'm going to have 10 minutes more to sort of set the stage, and then you'll have a half an hour for the discussion. Our goals for today, as it says in the programs, to explore ideas and frameworks for advancing interoperability between health and human services. And again, this is one of the first sessions. We've had a lot of excellent sessions. Some of them have been really fantastic, but setting the stage. But this is among the first sessions where we'll hear people responsible for different pieces of our crazy patchwork system that will give you examples, beacons, that that shine about how we can actually do these things. And then as part of that, the second goal is really to talk about how we weave it all together, the social determinants, the population and public health. Yes, a few of you in the room focus on public health and health, but one of the themes, all of you, most of you focus on social and human services, but one of the themes is how we can do it together, because in general, not only are there silos in your organization, certainly the health and medical is 98% of the time siloed from the things that you do. So that's one of the themes. And I've asked each person, to the best of their ability, again, in 15 minutes is going to be tough, just to tell you a little bit about their program, to talk about interoperability, since that's what we're here about, to try to emphasize to the extent that we can the learning system where we constantly correct course. Everybody in government, of course, has to be accountable and monitor, so how they've done that, and most importantly, what they're proud of, what they're not so proud of, and how it takes us forward. So real briefly, in 10 minutes or less, I'm going to try to offer you a few frameworks from my perspective, and that is one of trying to correct our crazy healthcare system to that of population health. And I'm pleased, Jim, for your stand-in for the Surgeon General. Very good, you and the other two colleagues. And we're probably, we would have benefited from the Surgeon General, but we certainly benefited from you and the other two. But population health is really the way that, in my opinion, we can blend things together. Why? I tried hard to find an interesting graphic, and this is from one of my favorite states, Minnesota. Anybody here from Minnesota? Nobody here from Minnesota, but we like Minnesota and other states, not only because they're nice, but because they really work collaboratively. And the innovation centers at CMS, again, taking medical care money, medical care, I know the statistic, 97% of healthcare money goes into medicine, 3% goes into public health, and half of the public health money actually goes for safety net medicine. I don't know what the statistics are when you add it all together, but those statistics are roughly true. But CMS is taking some of the medical care money and thinking about population health. And it's mainly been in the Innovation Center, where they're not talking about health maintenance organizations, HMOs. The new term ACO, Accountable Care Organizations, not to be confused with the ACA, which is the Accountable Care Act. And it really wasn't the ACA. It was really the PPACA. PPACA sounded too much like alpaca. So the market, I'm not making this stuff up, I promise you. So they decided we can't call it PPACA, so from now on we're going to call it ACA. So it really is PPACA. But the ACA did not have anything in it except giving people an insurance card. It didn't even have giving people EMRs. That was actually part of the stimulus package. But they had the idea of developing virtual organizations, sort of like HMOs, and they call those ACOs. That's a whole lecture in itself. But a little sleepy innovation, which we'll hear more about, are these accountable care communities. And the reason that's critical is in Minnesota, based on the University of Wisconsin, my laser's going bad, they estimated the impact on population health. Only 20% is getting person an insurance card for their medical care, 30% has to do with healthy behaviors, 40% has to do with socioeconomic factors, get them a job, get them a house, et cetera, and 10% is the built environment. So if one is really going to attempt population health just through great hospitals like Johns Hopkins, it's hopeless. That will get you maybe half of the 10%. So that's why we're all here, and that's why we cannot have population health without everything that you guys do and without making it interoperable. This is one of the great NICEA. How do you pronounce it? NICEA, close. I have actually read a lot of the great applied physics laboratory reports. They've been active, some of the system architecture. And by the way, all of these slides will be made available to you, but this just reminds you, it doesn't have to be rocket science. It's about different types of people, it's about different types of processes and organizations, and it's these different endpoints. And if you haven't, you should read these reports. They're quite good. They're available online. If you just simply put NHSIA, the first thing in your iPhone or Android, the first thing that pops up is actually this report, which is pretty neat. So I'd encourage you to read it. But this is thanks to Mr. Blair and your colleagues, and it would get one of my awards for more effective government. Whether or not it would have happened without the meaningful use, we are, in 2012, roughly 72%. In 2013, roughly 80% of all doctors in America have an electronic medical record on their desk. They now have an EMR. Now, what do they do with EMR? That's a different story. Do they know how to use it? Is that a different story? Are they collecting social data? Not really. Are they sharing it? with anybody in the room? Not exactly. However, you got to start. You got to start. So all of the information will be digital, and thanks to, we'll hear about some of the meaningful use, they're going to have to communicate, and if they're paid on the so-called triple aim, that's brought by Don Berwick, who was the head of CMS, although he was never officially certified because we won't go there, but a very innovative guy with his triple aim saying it's not just about the medical care for the people in the intensive care unit, it's about all the people out in the community. That's what the triple aim is about, and that's why we're here together. This is a framework that I've developed starting with a medical model with the doctor and patient at the middle. But to really think about, it's not about the doctor and patient. Even the sickest of patients, only is with his or her doctor for what, 1% of the year? And the rest of the time, they're in the community with their family. And even nowadays, when they are visiting, quote unquote, the doctor, they're not with the doctor. They're the practice team. The patient-centered medical home or primary care medical home, sometimes called PCMH. Most of you know about medical homes. In part because we tore down primary care, we have to rebuild it. And now the ACO integrated delivery system. But my point is to remind us it's not just about the medical model, it's about the organizational model, the community model. But for this presentation, soon the entire environment will be surrounded with digital data. The entire environment will be surrounded with digital data. Public health data, medical insurance data, social human resources data. Again, this I wrote for my medical colleagues. We could expand this on this side to include a lot of things that you do. And the mobile health apps that most of us have been using for the last 6 hours. But I think that increasingly the Fitbits, the sensors that people will be able to wear, the environmental information, and we haven't even gotten into genomics. So we have to learn how to make this interoperable and pull this all together. I'm going to jump right through. And this is a slide that I pulled off from the state of Oregon. Anybody from Oregon? There are 4 or 5 programs going on. You mentioned 2 or 3. Vermont, Minnesota, Maryland, because we're here, they're in a pilot mode. Oregon, where they're trying to do what we're talking about with the ACA, with medical dollars at the core, but trying to provide a community-based, accountable program that focuses on, this is a little hard to read, but you can download it in a few days from the webpage, but it talks about community, it talks about the home, it talks about primary care team, it has the whole population, and it thinks about how, in the state of Oregon, when you give people an insurance card, it can be fully integrated with all programs. So I encourage all of you to look at these, this is what Jim was talking about, look at these innovative models, and I would posit that those will be examples, particularly in those states, we should study, and we should make sure that the social and human services are integrated. So I'm going to now turn it over, oops, I don't know if you wanted to start on that, but to Hunt, who will talk to us from the perspective of the Office of the National Coordinator. In some ways, he and his group brought us here today.
So thanks, and I appreciate all the credit that you sent my way for things that the ONC has done. In fairness and full disclosure, I've been at the ONC for not quite 3 months yet. So yeah, I'm happy to take the credit. And yeah, ONC did give out $2 billion in grants, and then there's another $29 billion that's coming from CMS for meaningful use. So good afternoon. I was the former State Health Information Technology Coordinator in Vermont and also the Deputy Commissioner of Health Reform. And so what I've done is move to Washington at least most of the days of the week, visit my family every couple of weekends, to work on the intersection of states and the CMMI programs that we heard about earlier, particularly the State Innovations Model, and the future of health information technology coordination. Because as I think everybody in this room understands, the real future of federal health reform happens at the state level. And so even though the formal grant program that created a requirement for all states to appoint a state HIT coordinator is actually coming to a close early next year, the need for federal and state coordination and collaboration around IT could not be more intense. And so my job is to work with states and the ONC and CMS on how we can keep that going in the future. I will say that one of the things that struck me in one way before coming down to this part of the world, and that has really gotten only more intense since being here, is the I wouldn't say conflict, but the tension of having the words government and innovation in the same sentence. And I think that that's, it's a good laugh line, but it's also something that I think we need to take really seriously because as has come up in the discussions all through the day, we have these huge aspirations of what we want to do, and at the same time, there are a lot of entrenched reasons and people and legacy people along with legacy systems that make moving forward really difficult. However, that said, I am a guy who's actually very optimistic, and I'm also a person who's basically been fixated on and elaborating on this picture for a decade now, as my colleagues who are here from Vermont know all too well. So this is a history of the picture of the internet, the history of the internet, which started, as you probably know, with funding from the Department of Defense and with the design principle that everything goes through the Pentagon at the center. And it didn't take too long to figure out the flaw in that design methodology because if something went wrong at the center, then it went wrong across the network. And with a lot of pushing and pulling, which is nicely documented in a number of books, they moved ultimately to the distributed network model. And the main idea that I have to bring to you today is that it is only a matter of time until the digitization of health information and human services information follows the same track in history that happened with the internet itself. And it's, we're a little slow because healthcare is the last cottage industry in America, and we've already talked a lot about silos in the context of government and human services. So it's not an easy process. And it's also not an easy process because in addition to the technical challenges, the real, one of the main points that I like to make about this picture is that the business model of healthcare and the organizational model of human services is pretty much over in this centralized hierarchical structure. And so we're really trying to do something that's very hard. And I think it's important to recognize that because, for 3.5 years ago, when ONC gave out just about $500 million to support the innovation of supporting health information exchange in the States, a number of people thought, oh great, and in a couple of years that'll be done, and then we'll go on to the next stuff. And here we are now, and darned if it's not still really a struggle. And it's a struggle for lots of different reasons, in part because the technology has not been entirely ready for prime time, and also because just the hard work of pushing against the inherent structure is very difficult. However, I am a very risk-averse person, but I do believe in a couple of things that are safe to bet on, and one of them is gravity. And so, oops, forgot that was there. So we absolutely are going to move toward an infrastructure that is distributed in healthcare and human services. And the reason I say absolutely and talk about gravity is because data sheds are like watersheds. And so the same sort of gravitational force that pushes data out and down is going to be in effect in this area. was asked to talk about some particular learning system examples. So Jim actually did a great job of covering sort of the basic framework of what we did in Vermont. I'm going to focus on one thing in particular, which is the community health teams that he mentioned that are part of the Blueprint model. They connect our medical homes or their medical homes with folks in the community who are cross-disciplinary teams. And one of the most important things that we did was to create a web-based infrastructure, a longitudinal record and registry and a reporting tool that connects not just in the way that EHRs are connected to the Health Information Exchange, but connects a very clearly defined, fully structured data dictionary that is shared between the primary care practices and the folks in the community health teams, and then with lots of other folks, including, for instance, public health. So one of the great innovations that, again, this is more about cultural change than about technology, took a long time, was getting the folks from the public health department's smoking cessation program to be fully embedded with those community health teams. But one of the great real payoffs of that was that the physicians were able to find out that instead of just handing somebody a brochure and saying, oh, well, they've got this program, maybe you ought to hold up, they actually are able to see, oh, well, George went and had an encounter with a smoking cessation specialist and then is able to have a real conversation, not oh, well, I wonder how they're going to answer this question kind of conversation the next time they come back. Was asked to talk about accountability. So this system that we put in place had some and continues to have some technical challenges. And we started digging into it, my colleague, Dr. Craig Jones, and his team, and a number of folks started digging into what we called sprints, following that lean methodology. And 37 weeks later, so not really a sprint, we had gotten to a point where the clinicians in we were just talking about one community in Vermont, one primary care practice, one hospital, and really digging into some of the not insignificant problems that they were having with data integrity. And the test, the real accountability is, would those doctors who use that system and other primary care clinicians who use that system attest to their comfort with the validity of the data? And I would suggest that that's a really good way to approach this, to actually ask the end users whether the system is working for them. And really importantly, that 37 weeks of sprint really it was about 4 years too late. What we should have been doing is, as we implemented that system, been doing constant loops and making sure, were people satisfied, the next day, et cetera. And so I think that's a really important learning. And one of the other important learnings is that we're basically, I talked to Craig the other day and he said, we were sort of on a Mars exploration mission or something, because we were pushing so hard on trying to get structured data when the EHRs were really not capable of doing it. Craig and I harangued Dr. Blumenthal and Farzad for a couple of years, and not just because of us, but with lots of other people who were complaining. But to Brian's point earlier, speaking up is a really important part of this, of moving this whole agenda forward. Squeaky wheels do get invited to come down to Washington and spend time. So in meaningful use stage 2 EHR certification, we are taking enormous steps forward with the quality of the exportability of structured data. Not perfect steps, seeing the professionals who know better in the audience. We've still got a long way to go, but it is, one of the things that I think is really important to understand about this is a big experiment, right? This whole health reform thing and getting human services working together with healthcare, it's again, to emphasize just how challenging it is, I balance that out with, but the good news is gravity is on our side. So it's, it's worth getting up in the morning to keep slogging away on it. So challenges. I think the biggest challenge, absolutely, that we experienced in Vermont, and I'm seeing this as I talk to folks in states around the country, is keeping executive leadership focused. Folks tend to think, oh, IT, they're like dealing with that stuff, and what most of the policymakers to date still don't understand, and that I think everybody in this room does, and it's our job to help people, educate people on this, is that this stuff is not really about technology. Technology is just the enabler. The real important work is the cultural work, the transformation of people's thinking about what it can mean to work in a universe where everything is connected in this way. So that, keeping that focus, having long-term thinking, not just short-term thinking, is incredibly important. And a few key recommendations. So again, not easy, takes a long, long time. Got to be realistic about that. I mean, I think that we do ourselves a disservice by pretending that, this is going to happen quickly. It's not. I mean, there are legislative timelines that, all of us who worked in or around government understand we have to react to. But at the same time, there is reality. And so, you work inside the constructs of various magical thinking, and then you say, but we need to keep moving forward and what's realistic, and know that, at the end of the day, outside of evidently Steve Jobs, most of us don't have the ability to, bend the time-space continuum. So I think that you have to be realistic about that. I heard a great quote, which I looked up to try to check, because the internet now, you can see whether or not you're correctly attributing a quote. And so I don't think I am, the person who told me this quote, I don't think did correctly attribute it. So I'm just going to say, a former president who was a general in the Second World War has been said to say, if you can't get your hands around a problem, you need to make it bigger. And I think that does particularly apply to the challenge that we face here with bringing the worlds of health and human services together. There was somebody who said earlier today, well, we might be trying to put too many things into this box, and that could really be challenging. And I'm sympathetic with that, but at the same time, I think that going back to this idea of we're not going to stop digitizing health information, we're not going to stop digitizing human services information, this is happening. Let's make use of the gravitational effect that we can, and really do the best to make use of that. You haven't thrown up there? I'm doing okay on time? Okay. I got 1 minute, 2 minutes? Okay. So here I think is the, I can stop now, but I'll leave the two final thoughts. One is design with the end in mind. It's awfully hard in all the projects that we work on to get really focused on the near term and forget about the long-term vision. And I think that you're never going to get to really have the kind of integrated system that you want if you're not thinking from the very beginning about stuff that you can't actually even accomplish. Not too many people are going to get their criminal justice system and their healthcare system and their human services system and substance abuse all happily talking together, although there's some great examples of little people doing great work on that. And then the other thing is, it is incredibly important for all of us everywhere working on this space to cultivate people who can think about things that are complex and hold them in their heads and be able to kind of move around them and think about them and then return to them later on without having to start every time. Now, lots of people in leadership, they're not the kind of people who are thinking about that, but they need people who can do that. And I think it's, that is, the importance of that is not to be underestimated, because being able to find ways to communicate things that are complex to people who makes their heads start buzzing with the sound of bees in their head. You need to be able to have those kind of bridge agents. So I think that's incredibly important. So thanks very much.
Hi, I'm Mimi Toomey with the Administration for Community Living, which is a small little operating division within Health and Human Services. Up until about a year ago, we were we were three separate agencies. We were the Administration on Aging, the Administration for Intellectual and Developmental Disabilities, and then an office within the Secretary's office, which was for physical disabilities. So now the Secretary said, okay, you guys all kind of you all have different needs, but you all have similar ideas. You want to keep people living in the community for as long as possible, when possible. Let's put you all together because you'll be stronger. I don't know if any of you had heard of the Administration on Aging before today. Usually we have to reintroduce ourselves every single time. And now we're this new agency where people are like, what does that mean? So the Secretary very purposely chose the name Administration for Community Living because we didn't want to the disability community didn't want to have the Administration on Aging and Disabilities tacked at the end. We didn't want to have the Administration for Disabilities with Aging tacked at the end. We wanted to show that there was a common goal between the agencies. So that's where I'm coming from today. I'm also coming from the community. I've been a Fed for 10 years, but I've actually been in the field of aging for 25 years at the very local level in the city of Chicago, and not the suburb, within the city of Chicago, where we were having these same conversations 25 years ago. It's like, how are we going to connect health and human services? The hospitals don't get it. You know, you don't discharge somebody at 5 o'clock on a Friday and expect us to be there and answer the phone. So I'm excited. The Affordable Care Act came along. We have a visionary in our Assistant Secretary and Administrator for Community Living who said, while this law is about health reform, it's about getting people insurance, there is an opportunity for long-term services and supports. You just need to find it. And I want to thank people like Jim Hester, who used to be at CMMI, who saw that vision as well and helped move us forward. So thank you, Jim. And thanks, Jim, for getting me here today. So why are we talking about these people? These people are expensive. These people are, what are these? It's 14% of the population are spending 47% of the healthcare dollars. And we know, there was a study done by ASPE, which is the evaluation component within HHS, that said, if we tried to combine these health and these human services, if we looked at what supports those people need, we can drop that. There is an opportunity there. So we are pushing very hard in that direction. Again, we're looking at the Affordable Care Act as that opportunity. I'm very nervous about time because I could talk about this stuff forever. And I don't want to get the hook before I get to some of the important points. So hopefully this room knows what long-term services and supports are. We talk about clinical health. We talk about public health. There's two other legs to that stool that I think that matter. One is that community that provides the long-term services and supports, as well as the patient, or the client, as we call them, and their family caregiver. All of them working in together, and then Hunt, and IT. those people have to pull it all together as well. There have been several studies. HHS has been doing a lot of work around 30-day readmission rates. And there have been studies in fact, that said about 50% of the people that return back to the hospital on a readmission had nothing to do with medical reasons. It has to do with their social determinants of health at home. They don't have food. They don't have a ride back for the follow-up visit. So, and there's also have been several studies where they talk about nutrition, that you can have the perfect care plan. Everything looks great. The person goes home, discharge planning. They're going to, they're going to go to their follow-up visit, and they've already arranged a ride, and everything is terrific. But they don't know, that discharge planner doesn't know that there's no food in that refrigerator, and they can't cook. So that's really where we're coming from. That's the long-term services and supports, and that's the angle ACL is taking. So what is this system? Who is it? It's all of us. It's through partnerships, we do outreach and education to professionals, and through services, we do outreach and education to consumers and their family members. This slide just kind of depicts a short list. It's not all of the list for long-term services and supports and how we've got to connect those services, but it's just some of it. And partnership, again, with public health, partnership with doctors, partnership with hospital, with nursing homes, across the spectrum. Housing is an enormous issue. Housing with services. If it's public housing, we work with HUD. So some of the things is we were asked, what goals are there that we would measure our success? And so, again, we're talking about the Affordable Care Act, and we're talking about the integration between healthcare systems and families and community support systems. And the AARP, Commonwealth, and SCAN Foundation developed a state scorecard. Are you familiar with that? What does a good long-term care system will look like in a state? So they've got this, if you go to the AARP website and say, scorecard, you can see, how the states are ranked. Illinois is not so great. I'm from Illinois, that's why I keep bringing it up. But we're getting there. I know that because I know you're doing a design for the Innovation Center. So what they're looking at is support for family caregivers. AARP, about 6 months ago, did a report on family caregivers and families going home from the hospital, and about 60% of those caregivers were given very complex medical care to provide for their family caregiving, including about 30% doing wound care. I mean, think about infection, think about all of the things that can go wrong. And if you're a family caregiver and you don't have a nursing or a medical background and you're all of a sudden charged with figuring out the medication reconciliation, you're just asking for a visit right back to the hospital. Affordability and access to care. So your mother falls and breaks her hip. She goes to the hospital, she goes in then to skilled nursing for the post-acute benefit for rehab. You're in a crisis mode. You don't want to spend the time to figure out where do I turn to for help? And this is not just for people that are on Medicaid or on public programs, people that can afford to pay for private programs. So one of the areas that they look for in the scorecard is, is the access to information there? Can I find it very quickly? Minnesota's been brought up. They're very high on that scorecard. They're one of the better states. Choice and setting for and for the provider. So there are options to direct their own services. Instead of, yes, this is what we have, this is what you can get. Well, you know what? That's not what I need. I need someone to be there, to help me get my mother out of bed in the morning, instead of we can do meals 5 days a week. And quality of life, quality of care, and that includes using evidence-based programs. Evidence-based care transitions, evidence-based chronic disease self-management program. I know Vermont uses that as well. So we did, ACL, when the law came out, we did get a tiny bit of funding for our aging and disability resource centers and around care transition activities. We wanted to test. Our assistant secretary said, we think we want to play here. We've had this theory all along. If we just integrate health care with human services, we think we'll be able to save some dollars. Let's test it. Let's see what we can do. So we did. We gave 16 states were given grants to get training in primarily Eric Coleman's evidence-based care transition model. And let's see how we do, Are we going to be successful here? Do we, we've talked the big game, but are we really ready to play the game? Well, they did very well. They took the training, but what they found, and what this slide depicts is, they talk about care transition is just that reduction of 30-day readmissions. There is, I think the numbers here, out of 739 participants, they needed over 2,100 other types of service. So you need medication, great. I don't have the copay. I can't afford it. A lot of it was nutrition services, transportation, back to for their primary care physician. So this is a really important slide because we really want people to understand that it's beyond the transition and it's beyond the clinical side. Okay, so we're going to put the pieces together now. This is a true story. This came out of one of our rural states that did care transitions. Mr. P, and you know what, I apologize, the slide, let me get them all up. There we go, okay. So Mr. P, he's rural area, he was in the hospital, he had open heart surgery. He's also had problems with managing his diabetes. He lives alone in his own home, and he didn't want to go to the skilled nursing facility for his post-acute benefit. He wanted to go home. So the care plan, the discharge planner got with the nutrition folks in the hospital and said, this guy is having trouble managing his diabetes. Can you give me some material? He needs also some medications. He needs some follow-up, some home health, et cetera. So they gave him materials to read on managing his diabetes. a referral to where he can get chronic disease self-management or diabetes self-management. They gave him instructions for medication. Great, right? Mr. P can't read. So, and this is a true story, he could not read. So we had actually, fortunately, one of our ADRC counselors in the hospital who was ready to do the care transition. And because she understood, this coach understood it's beyond coaching, she asked those questions, and he confided in her. He said, you know what? I don't understand these instructions. What do? I don't know how to prepare the food. I don't know, what I'm going to do here. So she arranged to have the dietitian actually come and talk to him. She arranged to have the pharmacist come and talk to him. He still was not comfortable. When he went home, she arranged to have the community pharmacist come to his house. It seems like a lot of extra steps, but he has not been in the hospital. It's been over a year now. He did not have any readmissions, and the cost of that readmission was far more than what he would have received at the home. So, I've got about 4 minutes, I think. I want to talk a little bit about what the challenges are and what we could potentially do together. I know in some of you I'm speaking to the choir. Some of you I'm hoping to make new friends and see how we can better work together. So here's some of the gaps. We want to build a common language. There's the one area where the social service people and the health people speak completely different languages. What is it that we need to do to help build that common language? And our folks are nice social workers, and they're nice community organizations, and they collect a lot of outputs. They do not collect outcomes. So we want to figure out how we can help them collect those outcomes, those health outcomes. Supporting an infrastructure and coordination. Great, HIT, we want to really work with you. However, there's a lot of goodwill going on right now. Everybody's a coach. Everybody's helping in this care transition world. We had an instance where one of our clients, by the way, clients are patients when they go in the hospital, but we call them clients when they go back to the community, and went home from the hospital with their family caregiver. The family caregiver had 7 different phone calls from 7 different coaches with 7 different instructions. And you know what the caregiver did? Went to the ER with her mother and said, I don't know what to do, I give up. So who's coordinating these coordinators? Let's figure that out. We had a woman who, actually one of our colleagues in the state of California, whose mother had fallen, was in the hospital. She had to drive a couple of hours to be with her, and the mother's out of the hospital, and the caseworker comes in the first day and said, here's my card. I'm putting it on the refrigerator, and I'm responsible for coordinating all of your services, and so you don't have to worry about calling anyone but me. And she thought, oh, this is working. I can't believe it, but it's actually working. The next day, physical therapist comes in and said, this is my card. I want you to call me because I'm responsible for everything that you need to do. Third day, someone else. So again, there's a lot of goodwill. A lot of people on the line, everyone wants to help, but it's creating more silos. So how do we get that infrastructure together? How do we coordinate those coordinators? Packaging service and supports for the highest impact. We've got a lot of service providers. There's 20,000 service providers out there doing all of these various services. One does transportation, one does meals, one does bathing, homemaker, chore, et cetera. Health systems, managed care organizations, they don't want to partner with a bunch of one-offs. They want to coordinate with one entity in the community and have them figure it out. Just like we've got these complicated healthcare systems, but there's somebody who has it figured out. The community side needs to get together and figure out who's going to be that entity, who's going to lead that charge so they can better partner. Grants versus contract mentality. Our nice organizations in the community are used to grants and reporting so much, but not so great. So we just need to figure out how we better help them talk the business case, which leads to this last one, is the business acumen and strategic investments. Again, they're used to grants. The grants that come out of HHS and other entities for these populations is not meant to serve every single person out there. So we need to figure out how to strategically invest resources to help bring those folks to the even level of their healthcare providers. And with that, I think right on time.
Hi, good afternoon. I'm Linda Gibbs. I'm from the city of New York. I'm a deputy mayor, one of 7 in the city, and my portfolio is the Health and Human Service agencies, except, thank you, Mimi, because, actually, one of you mentioned it isn't too often that you can get the corrections and health and human services together. In my case, health and human services actually includes corrections, probation, and juvenile justice. And so the first project that I'll tell you about is, in fact, a data sharing among those agencies. So what this is, I think we have three projects I'm going to tell you about. Worker Connect, which is a federation of data systems of the Health and Human Service agencies. The second is the Access NYC, which is a client-facing application for clients to access their own information and information about programs that they're eligible for. And the third is PCIP, Primary Care Information Project, which is a electronic health record that we pushed out into low-income communities in small clinics and provider settings in order to really ensure that the lowest income, highest need neighborhoods had access to electronic health records. I start with Worker Connect because it is, in fact, where our conversation started. This project started about 10 years ago. At that point, I was the Commissioner of Homeless Services. And we didn't have a deputy mayor in City Hall the first term of the Bloomberg administration. There was just a single chief of staff who all the commissioners reported to. So in a way, we sort of had to grope around in the dark on our own to figure out how to coordinate our activities. And one of the things, the project that we landed on is we wanted to have our frontline caseworkers work together with each other around shared cases. And it was beautiful. We had a whole protocol. It was gorgeous. Everything was going to be holistic, and you know, there was going to be like great efficiencies and better outcomes. And we failed in that project because we could not figure out a way for our frontline workers to know about each other in real time. By the time you can get the system information up, that we just couldn't figure it out. So we took a step back and we said, we need to create a shared data system so that real-time information can be available to workers. And that's what Worker Connect is. So it is it's not a database, it's a federation of systems, it's real-time information. User groups are created so that if you built around business practice use cases, and the worker who is authorized in that use case has online access to this federation. It's I think about 6 or 8 different data systems that feed in a common client index that creates the image of the individual and then shares the information from all the agencies. The user groups have access to the information that is right for them, and so there's much more information than any one user group is allowed access to, but it's based on confidentiality and permissions based on their status as a worker in the system. Right now, we have 7,000 authorized city employees and 10 agency user groups. So here are just some of the examples. I won't go through them, but it's great from this perspective that it gives you a picture right now, not only of your client, but of all the members of the household of that client. And so it achieves 2 things there. One is it allows you to see a complete picture of your client, not just the crisis that got them to your attention, but it also lets you see the broader family situation for that client. And so you can get a sense if you have a teenager who is acting out and showing up in your juvenile justice system, well, now you get a bigger picture. You can see what is happening with the mom. Maybe there's a new adult in the household. Maybe there's a foster care intervention. You can see a bigger picture of what's going on in the household. And the whole point, and this is the motivation behind this system when we built it, was all about helping those frontline workers to think and act smarter on behalf of the clients. The one thing we were asked to do is to talk about some of the challenges. So I would say for Connect, we had a really strong, fast start. And in the first 4 years of the project, we built user groups. We got the source data from a mix of different agencies. And quite frankly, we sort of hit a plateau. and did not continue to develop the system on as fast a trajectory. And so with a new director of HHS Connect who's here with us today, Louisa Chafee, who's in the back here. Louisa, if you'd raise your hand so people can see you. Louisa has recently taken over the Connect project, and we went back to our planning documents and said, okay, let's set priorities for additional data sources and additional user groups. The one most important that outstrips everything as a request by user groups for data is our Department of Education data. And I have had this conversation with the Department of Education, at least 5 times, like the come to Jesus, we're going to do it now meeting. And they say, we're in. And then I go away and no follow-up happens, and, and they disappear back in behind their fortress over there. And they're great, they're busy. Oh my God, look at all the great things they're doing. They're really busy, but like when people are really busy, you just got to stay on them. So Louisa is committed, and so I want everybody to check in with her on December 31st of this year. She's going to deliver the DOE database to this system and connect it in. Just to give you other examples, we have our child welfare system in there, probation's in there. We have the biggest, the mother lode is our public benefit agency, the Human Resources Administration, not only because it's a huge volume of clients, there's 2 million food stamp clients, 3 million Medicaid clients, 300 and only because the commissioner really focuses 352,000 cash benefit clients. So there's just huge number of client cases in there. But more importantly, behind each of those clients is a massive amount of information. All those documents that they come schlepping into your office with, your birth certificates, your pay stubs, your leases, all that stuff is scanned and it's in a database. So all the user groups have access to that huge amount of data that HRA collects. And so, so many stories of how that helps, all of the workers that use the system to do their job and to make the client's life a hell of a lot easier as well. One, I just wanted to give you our next use group that's has started up, health homes. Part of the health reform implementation in New York State, the state took the 75,000 highest Medicaid users, and they said, we are putting these users into a very specific, first out of the gate management entity called, in this, creative health homes. That means a million different things, but we use it for this term here. And you had to apply. Health providers had to apply to be health homes, and if you passed the test and got the honor of being a health home, they said, okay, on a certain date you're going to get a dump of names, and of those 75,000, they're yours. Go out there, find them, and fix them, and bring down their costs. And so the HHS Connect was an incredible resource because it allowed them to input these names and the basic identifiers they have, and it just half of the game. Can you believe the sun is out? Half of you're looking at me. I'm looking at the sun. Half of the game was just finding these people. They're in and out of detox. They're in and out of jail. They're in and out of shelter, and they do not have a stable home. That's part of their problem. And so the Connect was used. We went straight there just for a locator device. But once you get there, and once you've sort of grabbed them, then all of the benefits around integrating the other care coordination pieces. Footnote on this piece, the health information, what we have is Medicaid billing records and guesstimating what's behind those billing codes and then trying to figure out what kind of a diagnosis. And that probably violates some law. Cover your ears, all the feds in the room. So we're not allowed to get the medical records. The medical record, and that's the other thing. When it comes to health records, domestic violence, HIV/AIDS, education, it's a one-way street. All of the other information can feed into those folks, and we can connect for the purpose of opening the door that way, but the door doesn't swing the other way, and that information can't go out to the social service providers. And so maybe sometimes people try to guess if you actually see a Medicaid billing code, what that might mean. But other than that, we would never know about any of that information. The other thing that's really important about this stage of the project is that we are bringing our non-government partners into the system for the first time. An additional legal barrier that we had to jump over in terms of actually giving the contracted providers access to the data because they didn't share the same legal status of the government providers. So I got 5 minutes left and 2 projects to go. Okay, there's a picture that shows how much it's used. It's like 60,000 hits a week in Connect. So Access NYC, this is our client-facing portal. The basic idea here is we want clients, people who are in need in New York City, to have an easy way to know whether or not they're eligible for government programs. And so, again, this is a project that was built by Louisa and remains within the domain of HHS Connect, so she's overseeing the development of this as well. The basic idea is, let's find every project, city, state, federal, let's try to get every benefit that's out there and allow a kind of like a benefits calculator. Who, I'm a woman, I have 2 kids, I make this much money, I have this much cost. What am I eligible for? So you put it in and it says, here are the things, and then here are the ways that you go about getting those benefits. And these projects might sound familiar. There are different forms of it popping up all over the place. And to date, we have put 4 of our benefit projects on where you can actually apply online. It's not just looking it up and then saying, good luck, go down to the office, but you can actually, the first stage was you could print out a form and fill it out and go down to the office. Now we have 4 significant projects you can see where you can apply online. The most significant development for this project is that to the extent that that technology allowed people to use that as an option that they could personally pursue rather than going into an office. What we are now doing with our Human Resources Administration that manages those large public benefit programs is they are going to be moving these programs to, the vast majority are going to be online programs. Now, there are going to be situations where you want to have a face-to-face, and anytime programmatically or policy-wise you want to have a face-to-face, you're going to keep it. But other than that, we're moving our public benefit programs to be the virtual client service center. So HRA, who is our partner, is going to take this Access NYC base and expand it out in order to automate their systems. This is this was driven by a cost consideration. It is going to reduce the headcount of the agency by about 2,200 individuals, and it's going to close a significant number of offices. And there's going to remain a redundancy of offices and staff to help individuals who are who cannot make use of it, but probably the more important thing there is in terms of helping clients, is that we are going to work with all our nonprofit organizations and get them to understand how to use the system, and really, in that way, push out access to the assistance and support for the system through the nonprofits. So that's a big, that's going to be a huge jump forward on Access NYC. The last of the 3 is a primary care information project. It's an electronic health record. Our Department of Health and Mental Hygiene built it. I think Farzad might have actually been the CIO there when, so he and Tom Frieden conceived it. They built it. Now we have 8,000 providers, 3 million patients. The whole idea here was to build to use public resources to help low-income providers and communities who wouldn't otherwise have access to electronic health records. And let's not leave them behind. We saw the chart earlier, 71.8% take-up of electronic health records. We can all guess who that last 19% is, right? And so this here was really trying to be purposeful about that. Some fun stuff has happened. So the electronic health record, you see that the adoption as a critical first purpose. The second was quality improvement. How can we then feed that data back to the users in order that they can see their practices? I'm going to show you something on that. Interoperability. This system is built to link right into the health information exchanges and to the interfaces. What do we call them in New York? I don't know if you call them the same thing. I'm not a health person. I'm a human service person. what are the health exchanges, the health data, where all the EHR records are? Rios, that's it. The PCI, you win. PCIP will be a member of the Rios so that the data can be shared. And then public health monitoring, that's the last thing I'm going to say. So I'm going to beat you. So here is an example of how we use it on the provider level. We created provider dashboards. And so this is way too small to see. I'm sorry, but you can sort of get a sense of the squiggle line. These are a bunch of medical conditions that patients have, and then there is the average across all practices, and then there's your practice. And so you can see, boy, I used to be good, now I'm bad. Boy, I used to be bad, now I'm good. Boy, I'm all over the place, I don't know what I'm doing. It's probably the first time these providers had a sense of how they're doing compared to the system as a whole. The other is we can see the population as a whole. So this is BMI for all 3 million people. And it goes from 20 and below in the pink, and then you can see it goes up, and then it goes way down. That last bar is 35 and over, BMI of 35 and over. You can get a sense of the condition of the population that's served in these practices. And so it gives the city a new set of data for us to understand some of these really significant health conditions. Another part of the EMR design that was in the circle over there is it's not just, it actually is prompting best practice. And so it's the tool is intended to ding you when something is due. Client comes in, you know, the 5-year test, whatever, colonoscopy or whatever it is, you know, it's on the list. Have you done this? Have you given the referral for your, put the paper down. I only got one more point. You're a very threatening figure. So it's really trying to prompt the providers around all of those things that you want them to do. I as a patient, I'm a bad patient. I'm lucky I go to my regular appointments, and I wouldn't know to say, you know, I need this, I need that. And unfortunately, a lot of providers don't do it. We know that. So here it's prompts helping them to improve their practice. And that's giving us what we're seeing. This is the baseline data, and this is just 2 years of progress. But you can see the compliance with some of those best practices among the 3 million patients. Well, I guess back 2 years ago, it wasn't 3 million, but of those patients in the system, what the system has done in terms of improving outcomes. So the last thing I'm going to say, and this was so interesting, and I didn't know this until Amanda Parsons, who is the Assistant Commissioner at Health who oversees this project, when she was just giving me an update about it. When Sandy hit New York City and we got all flooded out and everybody's running around like crazy trying to figure out how to take care of the city, one of the huge issues, as you can imagine, was the flooded healthcare system. Coney Island Hospital completely shut down. We literally have a picture of a rowboat in the emergency room of Coney Island Hospital. Health pharmacies, if you didn't have enough meds, you were out of luck. That was the thing when we did door-to-door, people did not have the medicines. The way that we knew whether we were ready to, like a lot of the redundancies that we were building, we had like all these mobile pharmaceutical vans coming in, we had the National Guard walking around with nurses giving out medicines, and the way we knew when we could stand down is PCIP. Because it is a real-time record of health encounters. And when we pulled the geographic areas that were flooded, and when we saw the activities go back to normal, we said we can step back. I mean, it wasn't the only way we knew, but it was probably the most solid way we knew. And so it was a great example of how something that was just really conceived as helping poor providers, poor communities, has emerged to be so much more. So that's my story. I went over, I'm sorry.
So 3 fantastic presenters, fantastic people with ideas and fantastic programs. But now we also have a lot of fantastic folk here. And as promised, we have about a half an hour, 25 minutes for open discussion. And I don't know if we need mics. Do we need mics? And yes, I'm told the mics at the desk work too. Just turn them on. So please, let's open it up. And I hope that you will lead a lively discussion. So who would like to go first? behind you. And then if you want to direct it to a specific individual, please say so.
Linda, it's not a question, it's a compliment. I have to quote Frank Sinatra, if you can make it in New York, you can make it anywhere. So good job.
Question for Mimi and a question for Linda. Your agency sounds very interesting, and there are efforts in other areas of HHS dealing with major federal lawsuits to get people out of institutions. I'm just wondering how much communication you have with those states that are getting Medicaid waivers to do many of the things you're talking about.
Right.
I reserve my Linda question.
We are working across the department, across other federal agencies. One of the reasons the secretary brought us together, this new agency, is that we can address some of these Olmstead issues. We're working with the Office of Civil Rights. We are
CMS?
CMS, absolutely. Yes, we are. HUD, yes, we are. There's a meeting that's going on today that I missed. That is something I know.
Was it at the White House? Because what's his name went?
It's not at the White House.
Oh,
but
Brian.
there is between CMS and ACL, we're kind of forming this policy and strategy around community living, and one of the major objectives is Olmstead. So it is bringing everybody to the table. There will be, and I'm being recorded and I'm going to be fired, but there will be a strategic plan that will be coming out for comment and for the world to see. So it's very, very critical, and especially.
I'll protect you.
Thank you.
And Linda, some questions. It's a pleasure to hear you almost every year talk about the evolution and the progress that New York City is making. From a client's perspective, have you been changing your privacy notice so that clients know that when they give information in one area that you're sharing certain information? For example, I can imagine that you're not sharing, let's say, the details of abuse for child abuse, but rather who's in the home and demographic information.
At this, we spent so much time on this. The information that's shared by user group is based on, they get access to all and no more than the information that they have a legal privilege to see. And the system, the security of the system is set up that you can, sort of open and close doors based on your user group. And so we haven't had to, we talked for a while, the alternative that we talked for a while was, the first was like the lawyers wanted like a 32-page client confidentiality waiver agreement where they'd have to answer questions throughout the 32 pages. We're like, all right, they're never going to understand that, nor is anybody going to take the time. So we've made many forays into changing client confidentiality rules based on if the user gives permission, then you can open up more doors. Basically have not pursued that, and have, partly because we've been able to make a lot of progress with even within the current confidentiality area, but I think ultimately if we want to really achieve the vision, we're going to have to tackle some of those legal barriers in the right way. And when it's, I actually very much appreciate the confidentiality laws, and am saddened when you see the effect of those to diminish your ability to actually help clients, right? And so there's got to be a way of making those, bringing these things together and solving it. We haven't tackled it yet. And maybe, Louisa, is that any more that I should add to that? Is that where we are?
I sometimes think that if we really did good outreach to clients, that they too would say, we want other entities.
All 3 million of them.
We have a question.
But we have to get there, yeah.
Question here. If you can introduce yourself and your organization too, please, when you ask.
Hi, I'm Shel Culp. I'm the Chief Deputy Director and Agency Information Officer for Health and Human Services in California. And what you've been able to do in New York is awesome. And I want to be, I want our state to be like your state when we grow up. Can you talk a little bit about, something that we heard earlier today that I think we suffer from in California, and it's that culture of not sharing. Can you talk a little bit about that, and then how that impacted, how quickly you could put things like the Worker Connect system in place, and what you kind of went through on that?
I think that key to this was leadership and ownership among the agency leaders, and this was a collaborative project of the participating agencies, and so the agencies saw that their commissioners were on board and were very invested in this shared data system and in making use of it. The second, we really got hung up. I would say at the early part of the project, there was an easily 2-year delay on the lawyers' desks. And I think it was perseverance, just total perseverance, and getting past the no's. Every agency lawyer, even if their commissioner said, I want it, the lawyers, and then, and they looked like pushovers compared to corp counsel that's, protecting the mayor against massive liability, the risk that you're putting the city in. And you just sort of perseverance and push, and to find out that half of it was myth. And there are tons of places in the law where sharing is not only a right, but an obligation. And so we said, let's just start there. Is it okay to share names? Oh, yeah, I guess you can. Is it okay to share addresses? Nothing, actually, this says that you should, right? And so it's just, and it's sort of like taking the lowest common denominator, easiest path, and starting to establish a culture of sharing, building the system that can now be a receptor of so much more. And so just like adding the private partner, nonprofit health home providers, that was an absolute no 2 years ago. Now it's like, oh, well, now that you make that point, maybe, right? And then we got some changes at the federal level in some of the standards on education data recently. So now other gates are opening up to allow us to dump in.
Do you have a question also? Linda, are you a lawyer also?
I am a lawyer.
So you can take on the attorneys a
Yes,
little more
and
easily than some of the rest of us.
I'm not really a lawyer. I'm just trained as a lawyer.
Close enough. Okay, over there, and then second over there, and then third. Go ahead.
Yes, Bill Davenhall, a board member of Stewards of Change. My question is there a complementary consumer portal to your system, and maybe this blue button approach that Todd Park keeps talking about, where consumers can get a complete record of all the information that is being shared?
I see. Okay, so Access NYC is our consumer, our client portal that does not now allow a client to see their full record. Am I right, Louisa? That's right. And so, but they should. What it does is, so for instance, a new client comes into the homeless intake center. This was a huge problem. Part of, you have to demonstrate it. There's a review of your situation, and you have to show me, what was your last address? I need your lease. How many kids do you have? I need their birth certificates. For the men, a guy walks in with, you're a criminal if you walk into with kids, right? Like, why does a guy have kids? This is all women with kids place. And so, prove that they're yours. Go to the family court. It's like there was practices that were just abhorrent. But part of what HHS, the Connect does is gives the client all that information. So you sit down with your housing intake specialist, and they have access to the data, and so they're getting printout of records that they've lost long ago. So you can only do that, though, with the assistance of a worker. You cannot now get your own, but I think we ought to be enabling that kind of capacity.
Thank you. We had a question over there, and then let's move the mic.
Hi, I'm Kathleen from Illinois. My question is along the lines of what Shell asked, but more to what sort of internal change management, I guess, approach or plan do you have to undertake? For example, you mentioned that 2,200 workers are going to lose their jobs and a bunch of offices are going to close, and these are the workers who are involved in Worker Connect, I assume they're union members. And so how do you manage that internally in your office?
The plan at this point is by attrition. We do not believe that it'll involve layoffs. There's turnover in these jobs that is pretty high. And so, and it'll be a sort of a gradual ratchet up as the workers ratchet down. Maybe with the mayoral elections and a new mayor in January, there might be some reconsideration of whether they want to see that many jobs go down, but our work plan is to build the capacity and have it working. The key, and I think it's really, and actually Florida, I mean, we are basically replicating a process that Florida put in place to you know, excuse me, who's this? Right, exactly, right, years ago. And so we're just learning from them and then using Access NYC as the way of, as our foundation for building that. And so it was, you know, it was a bit the imperative of the budget that sparked the creative thinking. And then you're like, well, hold it. This is actually something that clients want and like. And we want to create a capacity so that if somebody is, you know, for whatever reasons wants to go in and do things by hand, they can go to an office. But for the most part, it's going to greatly reduce the number of frontline offices and give people the convenience of being able to do it online.
Okay, you have the mic. Introduce yourself, please.
Question about, for the two federal officials, about the federal-state relationship as it's changed by all of this. Obviously, in a federal system and after the Supreme Court decision, there's an ebb and flow of federal government says you may, you can, you should, you must, and some states clearly have chosen to opt as far out of that as possible. So I think a fair policy question becomes, are any of the changes that you're talking about in federal systems likely to make states more accountable for the choices that they've made to opt out of these systems? Will there be better data or any deliberate data collected that will be useful in comparing states who opted out and went their own way, or comparing the different variations within the state? Or are we just going to say, that's it, everybody does their own, there's 50 systems?
I'm a career Fed, just so getting that out there. I don't see, I want to go back to what we do, which is, again, we're looking at that scorecard for long-term services and supports and looking at if we can get to those 4 main goals of making it a better system for consumers, those states will be measured.
And going back to the point that Jonathon made earlier, so most of the ONC programs actually come out of the ERA and the High Tech Act section of that, so it's less connected. I think your question is probably best addressed to folks from CMS. I would say, though, that in terms of the challenges of some states not being as robustly in favor of moving forward with health reform as others, that one of the things that we've looked at, I mentioned that I'm working on the future of state HIT coordinators and coordination, is in the current requirement is that it has to be somebody who's appointed in state government. And so we've talked to folks from states who feel as though that's not necessarily the most effective place to have that role, and that if there's a part of what we're working on is a model where if there's clear authority and accountability granted to that person, in some cases it could be the organization that runs a state health information exchange, that would make sense instead of it being within the state. So I do think that, you know, we're in a difficult time in our country, and one of the things that's important, I think, for all of us to try to do is to bring the conversation back around to a conversation with somebody this morning about this, to what are the things that we agree on. And so much of what we're trying to do and what we're discussing here is really driven by money, and it's not a red or blue kind of state issue, it's a green issue. And that even in states where folks have been slow to take up some of the health reform initiatives. We're seeing this in some of the state innovation model planning. as soon as governors realize that having connectivity across these systems is going to help them with their Medicaid budget, then suddenly it has a whole lot more appeal than it did when they were looking at it more narrowly.
Hunt, I hope you're correct. You know, the idea that the Republicans, governors or legislators are waiting for a health reform to fail, so in the meantime they have the feds come in. I'd never quite figured that one out. And not taking the tens of billions of dollars and letting people go uninsured, I certainly can't figure that one out either, but we'll wait and see what happens. But in the meantime, who has the mic?
Every one of you has some different experience with different stages of getting collaboration to start to happen, either between different agencies, in some cases at different levels. How do you go about, I guess, getting the agreement on what it is we all want to have happen, and what kinds of incentives, or if not incentives, other levers do you use to actually get the very hard work done of getting the collaboration happen, getting the agreement, getting, in some cases, data actually shared? What are the best incentives, levers, and ways to think about that problem, or the challenge?
I'll start. So I think that the biggest common denominator is the fact that we're all patients and are part of families that are patients, and so that that personal altruism and looking at our system that way. I mean, I think it's one of the unfortunate byproducts of the fact that we have such an atomized non-system of healthcare is that we don't sort of think of it as a group effort across our society. And so I think getting to that part of the conversation, I think that's back in the reform in Vermont was part of what was really successful, and maybe it's part of our town meeting culture. But we really came to a very broad consensus that we were trying to improve the health of the whole population of the state, and lots of different ways to do that. But I think that really basic common stuff can't be underestimated.
I think the state innovation models are going to be a great lever in those states. Since the Affordable Care Act was passed, I have never seen such cooperation across our agencies. CMS is enormous. We're a small agency. We've gotten into the business where we're introducing themselves to themselves because they are so big, but we're so small that we tend to go to all those meetings, the same group of people. But I have never seen the level of cooperation that we've had, and openness and desire to make this work and work for the various populations that we serve. And in fact, for the state innovation models, each of the operating divisions have staff that are on those core teams to help inform.
So for us, as I described, it was essentially the commissioners of the agencies getting together and wanting this collectively. And so they, as the founders of the project, were all in from the start in order to achieve that goal of collaborative case management. As we've sought, one important point about that is that they are the board of directors of the project and are the decision makers. And so while I'm maybe the chair of the board and Louisa is the director of the project, the board reviews and votes on all of the activities, and it's a principals only meeting, meet quarterly or so, maybe every 2 months, and not allowing substitutes. It sort of keeps a high level investment. The other thing I would say is that to the extent that we want other people's information from outside, the way that the case that is being made, basically making them want our information. So it's the guidance counselors at the schools who are our hook to the education data, because at this point, the doors are just going to flow up to them. The education data, until we get a use group that allows it to be shared, will not flow back down to the users. But let's make it, and then let's work, and let's think, and so it's based on providing a service to other sources of data.
We have about 8 more minutes, so let's keep the questions coming short and the responses short, because there are a lot of great ideas. Jim, you have the mic, so I guess you have the question.
Yeah, Jim Hester. One of the things that I talked about was the issue of good measures of population health so that we can track accountability and reward it. Because, Hunt, I'm interested in your thoughts, on ONC's attitude towards incorporating better measures of population health, particularly patient-reported perception of health status, which is the key part of it. And Linda, from the standpoint, you demonstrated with your charts, some of the factors of, health, the objective health status, BMI, smoking cessation, whatnot. Do you see it being in the city's agenda of trying to collect information again on the patient's perception of their health status as some of the things you would like to be able to monitor or track?
Yeah, I mean, I think one of the things that ONC has done in a really effective job with a very small staff is pushing this whole idea of putting the I in HIT, personal engagement in that, and that's something that the office feels very strongly about. And actually was just involved in a conversation Friday with folks, CDC, ASTO, and ONC folks about actually how to harvest that kind of population level information. One of the problems is that the data out there isn't as good as you'd like to be able to do that. But I think that to the extent that in the distributed diagram that all those little dots involve individuals, and individuals are feeding that information back ultimately. I mean, it's a long time, but like the same process that gives you the traffic information on your iPhone, which is really, or other smartphone, that's crowdsourced information, a lot of that, and we could be doing that same sort of thing with population health.
In terms of the user satisfaction, or consumer satisfaction with the services or behaviors, we not as part of the electronic medical records, but we do have the health department annually conducts a phone survey of thousands and thousands of people, and that's how we collect most of our major public health information.
Thank you. Again, introduce yourself and a quick question.
I'm Ivan Handler. I'm the CTO of our Illinois HIE. The question which I think Linda kind of alluded to, and I think it's a useful question. Right now, it turns out that the way we're trying to keep patient confidentiality in the medical world, but I think it's also true in human services, is to sequester information and restrict the flow of information within the services that serve clients. While the real concern, in my understanding, is not what the lack of confidentiality would do inside the service, as much as the real aim is to prevent information from flowing outside the service, and have people considered maybe that it might be a better idea to try to do a better job of keeping the information within the service to guarantee people that their confidential information is not being used outside the service, rather than restricting information which potentially benefits people in the service. I'm thinking primarily about healthcare, but I think it's also true with human services.
Mimi, you'd like to respond?
Yeah, just real quickly, we're finding, again, I was talking about the readmission rates in hospitals, and hospitals keep their information close. So when our clients who have a care plan that are already in the community go into the hospital, we don't know. And that's the problem. And so there's a couple of areas like Cincinnati, some of the better cities have figured out how to do that. At least they're at the point right now where the local area agency on aging will get an email saying, hey, your client who you have a service plan is hit our ER, they're going to stay here, but your caseworker needs to come over today so we can begin to amend their care plan. So when they go home, there is no disruption in service. And so I don't know if that's your question, but I think I'm seeing kind of the opposite, that we need to spread it a little more, where we share the information more to both the health and the human service side.
As we were working on the agenda, one of the questions came up was about the soda issue and the relationship between soda and public health. So I'm really interested in how you guys thought about that, because it was a tremendous public relations extravaganza, and I know there was a lot of thinking behind it.
You want to know what's really great about that issue? The idea came up from the policy unit at the Department of Health and Mental Hygiene. The agency is remarkable. It's I have such awe of it. They have an incredible. Sometimes the political people at City Hall could strangle them because they just have this fierce independence and they drive totally toward public health, and they invest a lot in research, and they invest a lot in bringing public health officials and doctors and researchers into the organization, and they constantly are studying what the emerging problems are and what are the potential solutions. And so it literally came on an array of initiatives that was presented to the commissioner, and that the commissioner then presented to the mayor. And you know, it's if you've worked in public environments, so you know, 3/4 of the ideas, crazy, good, bad, everything, 3/4 of them wind up on the floor, 1/4 get advanced. Of that quarter that get advanced, maybe 5% actually make it to the finish line. Now, we're teetering on the finish line because we're actually, next Tuesday, the appellate court is going to hear the soda industry won its initial challenge to the case, to the size limitation, and the appeals court is hearing it next week. So, and I think that's great. Now, you know, there's a million other stories about, you know, first convincing the mayor that it's a great idea, and, you know, and then once he's convinced, he forgets that he didn't think of it himself. And then, you know, well, obviously it came from the mayor. Did I say that? It obviously came from the mayor, right? And then, you know, and then all the naysayers, right? All the naysayers. You just got to keep persevering.
Well, it just seemed like such an obvious issue in so many ways, to talk about obesity and the issues associated with that, and to take that head on after the smoking ban, it just seems tremendous. I was just curious what the backstory would have been when the idea came up, and what were people saying at the conference room table around that?
Well,
And, you know,
joint.
Well, the last thing
ahead.
I would say is, you know, if there was a case to be made for it, it was simply the obesity data in this country, and the least useful input to obesity are those, you know, the sugar-sweetened beverages that offer zero nutritional value.
Well, those of you from New York, you can stock up on the way out the door. I think but we at the Bloomberg School of Public Health honor you and the mayor and the analysts that work for you, some of which perhaps were trained.
Exactly.
So if you can join me in thanking 3 great speakers doing 3 great things.